colleagues, good morning and welcome in this webinar. It's Marco Tallarico and today the topic is the COVID-19 coexistence. I would like to share with you my experience about what we know, what we don't know and what we should know about this pandemic. I live in Rome and I work in my dental clinic that is located in the same city. I'm graduate in dentistry and specialist in oral surgeon. I'm certified in implant-based therapy by the European Association of Osseointegration and I'm active member of several academies in Italy and worldwide. My clinic is also a training center of the OSSTEM AC Europe that I really want to thank to give me the opportunity to share with you my experience in this webinar. Fortunately, my clinic is located in Rome. Rome is located in the center of the Italy. As probably all of you know, Italy was very interested in the pandemic, but particularly the north of the Italy, that was one of the most interested part of the world about this pandemic, particularly in March when the epicentrum is located near Milan. Rome is located in the center of the Italy, and the center and the south of the Italy was very less interested by the pandemic. And I clarify this point later when we speak about the risk calculation. Very quickly, I want to introduce to you my dental clinic. This is the waiting room, the baby corner, where unfortunately today we remove all the toys and objects about the general rules against the pandemic. This is the office and I have 3 dental units. This is the first and the second that are very similar organized. The surgical room, very nice organized sterilization room, dental lab and photo corner. But we also have a meeting room when we take meetings, also live streaming and practical hands-on. But unfortunately, at now we have online educational. So, why this communication? Because dental community is very concerned and confused about this situation, maybe because there are various recommendations about protecting ourselves and our patient and the staff against pandemic from coronavirus. The concerns are most because most patients are asymptomatic and dentist is a very risk of infection due to aerosol produced during dental practice. But unfortunately, if we ask it to me, what is the most effective protocol? Probably the right answer will be, I really don't know. Because at today, we have not yet evidence about coronavirus. But we know the dentist is like a risk for disease transmission in general. Science is very good, but sometimes science is far from perfect. And also because the risk depends on a lot of specific procedures. So I want to be very clear that this webinar is not a standard of care or official regulation. And of course, it not creates legal obligation. But I just want to give my opinion for dentists in providing a safe and handful workplace for their practice. What is the difference between an opinion and evidence? Evidence is based on real, objectively and transparently fact. but the opinion is often necessary if we have controversial fact or, like for coronavirus, no definitive evidence yet. So we need to match science with common sense, and this is the concept of opinion. Let's go back. In March 2020, the World Health Organization stated that we are in pandemic from novel coronavirus that started in December, maybe before, in Wuhan, in China. The coronavirus was identified and named in February 2020 in all the world. Coronavirus is RNA virus with a mutation rate, and this make a range of clinical features from this virus, from asymptomatic patients to severe infection that sometimes may require hospitalization, also in intensive care unit, and justify also several deaths about this disease. Our problem is that, as most of the virus, COVID-19 can be transmitted by contact, that could be direct or indirect, droplets, spray in short-range transmission, but also aerosol in long-range transmission. But let's go back before pandemic from coronavirus. In 2003, the Center for Disease Control and Prevention already released some recommendation for dental air care personnel safety and program evaluation. And in this paper, CDC cited a paper from 1991 that already speaks about coronavirus. Of course, different coronavirus, but the same family. But already in 2003, we have guidelines to protect about infection. So, another study in 2018 speaks about possible transmission in dentistry, and authors stated that transmission resulting in infection cannot be excluded in dental office. Transmission could be from direct contact, indirect contact, by blood-to-blood contact, but also by dental unit water and aerosol. So, dentist is a high risk of infection before pandemic, but also today. So we need to understand what is changed before and after pandemic. Why? Because healthcare workers are always at risk of infection. I like to define the risk and how to manage the risk. Of course, the risk cannot be ignored. We need to understand and we need to take into consideration the risk to protect patients, our staff, and ourselves. The risk could be avoided or transferred. So if I want to maintain my clinic closed, I can wait to treat my patient, postpone the treatment, or I can transfer my patient to other clinic. But I want to speak about how to reduce the risk and make it acceptable. Sometimes we can also take some advantage by this situation. So, at the beginning of the pandemic, in Italy, like worldwide, the risk was not acceptable for dentists. For example, in Italy, the risk was very, very high, particularly in COVID-19 hospital, in the epicentrum. As I told you before, was in the north of Italy, and in the peak of the crisis that was in March, when dentists had not acknowledged about the virus. So in March 2020, risk was not acceptable. And how I can manage this situation? In my city, in Rome, I received from the government the stay-at-home rules, lockdown in March 9th. So I stopped my practice for 3 weeks only dental emergency, according to the American Dental Association. The 3 weeks later, reorganization. I started to came in my clinic to reorganize for the personal protection equipment, to reorganize, to sanify, and to treat only urgent dental care. 3 weeks later, after Easter, I always treat urgent therapy, but other urgent dental care according to the ADA. So I took 9 weeks to stop according to the general rules, to reorganize, and to be ready to start again. And in this period, I have some question. What is the risk in my city? As I told you before, the R0, the R0, as is named worldwide, was very high in March in the north of Italy, was 3, but today in my city is very less than 1. So my question was, can I avoid treatment of COVID-19 infected people? How I can reduce risk for dental healthcare workers? How I can reduce risk for people, for my patient, for my family, cross-infection? I have all necessary PPE in my clinic. So at the end, is my clinic ready to restart? Maybe March not, but today I have an acceptable risk and I started again my practice. I also publish guidelines, but is like this webinar, an opinion about the consideration on preparing dental clinics for COVID-19. And I work this manuscript about the 3W, what, when, where, for example. What kind of measure to protect healthcare workers, staff, and myself? What kind of measure to reduce risk of infection? When, as I will explain, before dental treatment, during dental treatment, or after dental treatment. And where I identify, also according to general guidelines worldwide, different area of risk, high, medium, and low risk zone. Starting with general consideration, as I spoke to you before, local geographic orders are very important because they depend on the condition in a community. So the local health officer may issue or update the rules about stay-at-home orders. In Italy, as I told you before, we received stay-at-home orders after lockdown in March for several weeks, but dentists can reorganize our activities to be ready, and we received also official recommendation to start again our practice in May 4th. Adequate supply, we need to check that we have all the personal protective equipment and sanitation supplies to reorganize our clinic, all the materials for screening and testing our patient that become in our clinics, and also visual sign in order to teach the patient about the general rules that we have to take inside our clinic. So the premium movements is the prevention. Prevention play an important role in protection from all the disease in general and may able to reduce the risk of cross-infection. Of course, I want to be really clear, all the people have to be considered potentially infected, but we know that people that are thought to be most contagious when they are most symptomatic. So it's very important to make a triage and survey that could be taken before the visit, the day of the visit by phone, or immediately in the office. And this is mandatory to evaluate the risk level and to reduce the risk level. So we have to ask to our patient if they have cough, shortness, breath, fever, or other symptoms, if they had contact with confirmed cases, if they are in quarantine, isolation, or also we have to postpone vulnerable patients in maybe some weeks in order to reduce the risk for these particular patients. So with the prevention we can reduce a lot the risk to treat COVID-19 infected people. And also we have to follow general rules. The questionnaire, as I told you before, but also I want to highlight that we have to assume the patient that the dental clinic is safe. General rules are rules that we use worldwide: avoiding assembly of people, keep social distance, stay alone or maximum with one companion if needed, for example, if we treat kids, leave in the waiting room potential infected object, hands clinic, that very important, and wear the face mask up to the dental chair. About the gloves, I like to give my opinion. Patient can also wear the gloves, but we ask to discourage when we came in the clinic, because unfortunately some people wear the gloves all the day and they touch everything, including food or other object, all the day. So we encourage to remove the gloves to hands and washing the hands, and then we can give a new pair of gloves when the patient came out from our clinic. So just with the prevention and general rules we can reduce the risk to treat COVID-19 infected patients, and this is the first step to reduce the risk from avoid treatment to make the risk more acceptable. Then we have measures to reduce the risk during dental treatments. I want to speak about the routes of COVID-19 transmission. The transmission of this virus is not limited to the respiratory tract and fecal oral transmission. We have several studies that speak about possible transmission about the high mucosa. Of course, we know the direct and indirect contact of the virus. In dentistry is very important droplets and aerosol that could transmit the virus in short and long range. So, but we also have transmission about the blood, and the virus was isolated by the saliva. So we have a lot of possible route of transmission. So we need to understand, measure to reduce the risk, and some tips and tricks. For example, some tips and tricks that we already used before pandemic is the use handpiece with anti-suckback ability in order to reduce risk of cross-infection and that the virus remain inside the tube of the chair. Use the rubber dam when possible to reduce the risk of aerosol making isolation of the tooth, of the teeth that you have to treat. We also aptly ask to the patient to mouthwash for 3 minutes with alcohol-based mouthwash or other disinfection that are able to reduce the risk, to reduce the amount of bacteria and virus inside the patient mouths. Particularly in this pandemic, we also organize the workflow based on a chain of control, identifying some area of risk. You can see a picture, but later I will explain in a bigger picture. Identify the area of risk, a high, medium and low risk zone. So we need to reduce the aerosol, and we can reduce the aerosol. How I can reduce the aerosol? With the particularly designed suction evacuator, encouraging manual scaling, for example, for agent treatment, encourage the use of speed, increase and pace instead of turbine and pace, encourage the use of digital impression instead of conventional impression, and also to add sodium hypochlorite to 100 milligram liter in self-contained water system. There are several publications about these tips and tricks to reduce the risk of infection during dental treatment. As for before, we need to reduce the amount of virus because the risk of infection is higher if the amount of virus is higher. So we need to reduce the amount of aerosol and amount of possibility to contact. Other mouthwash that we can use are hydroxyl peroxide 1% of povidone 0.2%, and we can find everywhere on the market, on the internet, etc. This is the areas that we identify. The dental chair is the red zone because it's risk for direct and indirect contact. Then we have orange zone, about 3 feet from the red zone, when the risk is for indirect contact from surface or from the air. Orange zone and also laboratory, changing room, sterilization room, toilet and office, because are all potential area that patient or staff can touch and can contaminate for possible indirect contact. All the clinic is considered yellow zone, is a low risk zone because we cannot exclude possible contamination. So, what are the measures to reduce the risk after dental treatment? Particularly, we have to reduce the risk of aerosol and cross-infection. We have proper workflow from the patient discharging and dental room disinfection. Before I speak about possible tips and tricks to reduce the risk at the dental treatment, but it's also important to reduce the risk of cross-infection. I think that it's very easy to protect ourselves and to protect the staff because we know the possible route of infection and we have adequate personal protection equipment. And I think also that it's most important to focalize to reduce the risk of cross-infection. So, after dental treatment, proper patient discharging, proper dental room disinfection. The dentist already do a very nice disinfection of the dental unit, but identify the red and orange zone. I think that we just need to improve the area that we have to disinfect between patients. So we take 15-30 minutes between each patient in order to be sure that all the possible risk zone, red and orange, are decontaminated between each patient. And then we perform a complete decontamination of all the clinic, including the yellow zone, at the end of the day. How I can do this? Reducing the overall number of patients per day, but also with all the personal protective equipment that the staff have to wear also during disinfection. And at the end, this PPE must be carefully discarded. Help patient to properly leave the dental chair and has to frequently wash the hands of all the staff. So, I spoke before about the chain of control and perimeter area. As I told you before, as I show in the picture, all the surfaces in the dental clinic could be contaminated, but identify high and medium risk zone, the decontamination can be easier, just to extend area on disinfection and time between each patients. We already used proper disinfectants certificate for COVID virus because we already use disinfection for other disease. So there is not evidence that adjunctive procedures are needed just to extend the area and take more time. We also have to extend the area of disinfection in the office, because the secretary is not used to wear PPE, but she must, and we have to extend disinfection also in the office that we identify as orange zone. And always maintain general rules also within the staff: social distance and hands cleaning. So again, we have high risk, but we can make the risk more acceptable, reducing the aerosol with the mouthwash of the patients, using digital impression, rubber dam, wider suction system, manual scaling, etc. So are very easy tips and tricks to reduce the risk. Speak about aerosol. We need to understand the risk of infection during dental treatment, because most of the dental treatment produce aerosol. For example, from the dental laser to high-speed MPs, electrosurgery units, ultrasonic scaler, air polisher, profi angles, and instruments to eye water syringe. Aerosol could be a mixing of water, saliva, but also blood, debris, and microorganisms, including virus. Inhalation of these particles in the aerosol that are produced during dental treatment may cause adverse respiratory health effects bidirectionally from the patients to the dental staff and vice versa. There are several studies about potential risk of infection in dental practice by aerosol, and this study started from 2004 or also before. So we already should be able to protect our staff from aerosol, because we already know that aerosol is dangerous. So we just have to understand the risk of infection transmission by aerosol, and we need to make some little change according to new pandemic, because as I told you before, already in 2004 we have general rules and we have several studies that confirm the possible transmission of the disease. And this study, for example, concluded that although direct disease transmission has not been confirmed, is very possible. So, as I told you before, we need to understand and we need to consider very well the risk of infection. I don't want to make very safe our practice, but I'd like to share several studies before pandemic that already understand the risk of aerosol transmission. So even if the disease transmission is not confirmed, it's very possible. But because it's not confirmed, because dentists already protect ourselves and the staff from aerosol. But I want to explain a little bit more. We have different like of particle sites that are spatter, droplet, and droplet nuclei. In dental setting, most 90% of the aerosol are very small. What is the difference? The difference is that spatter and droplet can remain in the air for a short times and can reach short distance, maybe 1 to 2 meters. But droplet nuclei can remain for more times. Some study showed that can remain from 30 minutes to 2 to 3 hours and can reach longer distance, particularly by higher ventilation, because they can move in the room also for longer distance. So the evidence for the 2 meters rules cannot be really accepted, but we can take some precaution and prevention to reduce this risk. First of all, to reduce the aerosol, increasing suction systems, and to make air ventilation in the room. This is some picture that show how the splatter can reach short distance and very few times, but very small droplet nuclei can reach longer distance and can remain for more times. So again, we need to understand this situation in order to take some precaution about the possible infection. As I told you before, people are most infected when they are symptomatic and when our codes needs, or in dental care, producing aerosol. So again, prevention for the patient is very important, but we can also minimize the risk in practice. What about indirect contact? We know that aerosol in the area can then deposit on surfaces and can remain up to 72 hours, 3 days in plastic, up to 1 day in carbon, up to 9 hours in copper, up to 5 days in glass and ceramic. But suspended aerosol can remain up to 3 hours. So how we can reduce this kind of risk? As I told you before, we need to reduce aerosol, and we have several possibilities to reduce aerosol, I spoke before, but we can also increase the air ventilation in our clinic. But again, in 2015, we already have general rules about this kind of the possibility to improve air purification and air ventilation. In clinic, we already have the possibility to increase the air with the window, or the clinic that have not window should have air purification systems. And there is not evidence at today that adjunctive air purification system are better than natural ventilation by windows or natural ventilation by standard purification systems. So it's very important to check the clinic and to allow for proper air ventilation by natural ventilation or artificial ventilation, and this allows to reduce the risk of direct and indirect contamination. So again, just to take a summary, in this study, authors recommended to improve the distance between patients, but in clinic it's not possible to improve the distance between the doctor and the patients, but we can improve the ventilation. So just to summarize, the aerosol can be reduced using dedicated suction system, reduced dental treatment that create aerosol, but also increasing air ventilation systems. Of course, we need to wear the right personal protective equipment. About this topic, I want to be very clear and very short, because we don't need to speak a lot, because dentists already used personal protective equipment. We just need to change a little bit. For example, we use every day surgical mask, and some colleague of me give the possibility to use 2 opposing masks in order to improve the capability to stop the virus in both directions. So it's very nice tips. But for example, about the FFP2 or N95 respirators without valve is very important. Personally, in my clinic, we use surgical mask for normal conversation, for visit, and we use FFP2 when we treat the patients, and particularly when we produce aerosols. Of course, we use dental loops and face shield in order to protect the face from all the surface 180 degrees. We use gloves every day. We just improve with 2 pairs of gloves, because maybe 2 pairs of gloves are important when discharging PPE, in order to have the second pairs after discharging the potential infected pair of gloves. Dispensable head and shove cover, in order to reduce the risk to contaminate ourselves, and also dispensable gauze. As I told you before, we also insert wider suction system in order to reduce the aerosol. So, as you can see in this slide, we just change a little bit more, because we already know in our clinic all of this personal protective equipment. We just improved the number of PPE that we used to reduce particularly possibility to infect ourselves and our staff, but also we need to reduce possibility of cross infection. So it's very important to wear and to accurately discharge the PPE after treatment. So, as I told you before, surgical mask can be used safely in the procedure without aerosol, and FFP2 or N95 are dedicated for a procedure with aerosol that, as I told you before, are the most treatment that we perform. It's very important, according to local rules by local authority and instruction for the mask manufacturer, the FFP mask and gown can be reprocessing. I used Gentle program in my steam vacuum, and I think that this is very important, because at today the availability of PPE is limited. So also here I want to be clear that some PPE is possible to reprocess. So it's very important to check with the manufacturer. Of course, I agree that PPE should be used for each patient and changed for each patient. And we do it, but today the availability is very limited, so we reprocessing according to local authority our PPE in order to have more disponibility in time. And also follow recommendation, not only to hand washing, but also to wear and discharge PPE. Very quickly, I want to clarify that there is no evidence that full cover, particularly mask, valve are better than others to protect the patients. Then they reduce the respiratory function, reduce the working ability, but particularly fully protect the operator but not the patients. So improving the risk of cross-infection. So it's my personal opinion that this kind of PPE are not needed. But again, we have already intraoral evacuator. I just change with some evacuator with large diameter. Extraoral evacuator are very interesting, but they are particularly dedicated in some medical field that don't have intraoral evacuator. So there is not evidence that in dentist we need extraoral. Of course, if you want, you can use, but we already have intraoral evacuators. About the dental units, it's most important that water and air should be discarded after each patient. Anti-retraction device must be used to avoid cross-infection. High volume evacuator, large diameter, as I told you before. Volume of air in a short time, which reduces the amount of bioaerosol, but also internal treatment adding of 0.2 ml of sodium hypochlorite for liter can reduce the risk of contamination. Some dental chairs have external bottle in order to use dedicated water with sodium hypochlorite, for example. all of these suggestions, PPE, FFP2, face mask, suction system, air ventilation, water treatment, again reduced the risk, making it acceptable. So, just 1 minute, I want to conclude to respond on some question. Is safe to go to the dentist? Are dental workers protected? Are dental clinics safe? Maybe if we can go on March 31 at the peak of the crisis, this is a very interesting article that highlight that most doctor and dental health co-workers are very fear to work in this situation. But as I told you before, in March we have not knowledge, high risk of contamination and general rules to stay at home. Now I think that we are able to reduce the risk and make it acceptable. Of course, if you go on Google and you find about dentists and COVID, we have a lot of data that the dentist is very high risk. New York Times, CDC, British Dental Journal, but very, very, very interesting is that we already have the risk. But to date, in the US states, cluster of healthcare workers positive for COVID-19 have been identified in hospitals setting and not in the dental clinic. So we are at very risk, but we are able to protect because in the past we already received general rules against hepatitis, against HIV, against other disease that are very risk for dentists. So most important is prevention, protection, mouthwash and high volume such evacuators, very important to reduce aerosols, but very, very important is to have very clear the problem and to have very clear guideline and recommendation. I just hope that the discussion help you to have a little bit clear the situation, and from me and from the AC Europe, I want to give you good luck and stay safe. In the next step, will be my pleasure to respond to our questions about this coexistence with the virus. In the second step, we have a Q&A section. So for every question, please send me an email, and in the next step, we take another discussion on your doubts about these pandemics. Thank you very much.